Hello, and thank you for joining today's webinar. This webinar is aligned with the type of content you will find at Sigma's Creating Healthy Work Environments conference that occurs March 20th through the 22nd next year, 2026 in Washington, D.C. Abstracts are open until October 3rd, and we're going to place a link for the call for abstracts in the chat now and at the end of the webinar. Today's webinar is eligible for 1 contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. No one with the ability to control content has any relevant financial relationships to report. To receive contact hours for this NCPD session, participants are required to attend the entire webinar and log into our learning management system to complete an evaluation form. Information on how to access this will be emailed to all attendees 1 week after the webinar. This webinar is being recorded and will be available via the Sigma repository within a few business days of this recording. Following the presentation, if you have time, or if we have time left, we will have a question and answer session. You'll see on your Zoom webinar control panel that you can send a message through the Q&A feature, and this is where you can type in any question you'd like to pose to the presenter. Be sure to hit send so that the message makes it to us, and please use the Q&A for questions in the chat feature to interact with other participants. It's too easy to lose your questions in the chat because it scrolls by so quickly, whereas in the Q&A, it keeps them stuck in one place where we can see them. We would like to thank our speaker for sharing their expertise with us today. Of note, the thoughts and views expressed are that of the presenter and do not necessarily reflect that of Sigma. Vanessa Cameron is a good colleague of mine that I have had the privilege to work with probably for the last 5+ years. She's a nursing professional development specialist and has held roles in academia, centralized and decentralized continuing education, and clinical leadership. She has a current focus on nursing continuing professional development, inclusive learning, and increasing awareness and equity for disability within healthcare. Vanessa became disabled after 10 years in nursing and is now a full-time wheelchair user. This experience created an instant shift in understanding of discrimination and ignited a passion for sharing her story and knowledge with other healthcare professionals. She is currently progressing towards her PhD in nursing from George Washington University, with a focus on inclusion in the workplace for disabled nurses, and runs an education and consulting business focused on inclusivity, professional development, and ableism. Welcome, Vanessa. We are so excited to hear from you today.
Thank you so much, Jen. And thank you everyone for choosing to make the time to be here today. I want to thank you in advance for your attention. And whether you are watching this live or the recording, just thank you for being here and for being interested in bringing some disability into the conversation within the nursing profession and healthcare overall. Just you being here is what starts to make a difference. So I am hoping that by the end of this hour that we'll spend together, you will be able to identify one benefit of increasing disability representation and awareness within healthcare environments. In order to reach this, we're going to look at disability overall and have a better understanding of what disability is and what ableism is, look at health disparities and professional inequities, and then identify some strategies to address barriers that are currently present within healthcare. And most importantly, I hope that through this conversation, you have a chance to do a little bit of reflection on your own experiences and your perceptions around disability and disability inclusion within healthcare. So to start, I know Jen shared a little bit of my story, but just to set the stage, I think it's important to have an understanding of my own professional journey. So this image on the screen here is me a little over 4 years ago. I was in the best shape of my life, actively training. I was working in an emergency department as a nurse educator, running the residency and continuing education programs. And one day after this picture was taken, my life changed instantly. I had an awkward fall while I was out rock climbing. I broke my back and I damaged my spinal cord. And in a split second, every single thing that I knew or thought that I knew about my life changed. Now, of course, there's all the physical changes that I'm talking about, but there were also a lot of changes around my own self-concept because I had such a lack of awareness about ableism and disability discrimination within healthcare that I really didn't understand how to combine being disabled and being a nurse. And what was this new self that I was trying to come into? It was really a full-on personal and professional identity crisis that I was going through. And I think that is because disability is so often overlooked and left out of conversations when we're talking about healthcare professions and engaging and being a carer, someone in healthcare or in nursing. So I say all this because when I became disabled, my previous ignorance about disability and ableism and discrimination in healthcare wasn't just not helpful, it was actually really harmful for me. However, I am nothing if not a creative, flexible, and probably quite a stubborn and determined nurse at heart. And so, even with a kind of being in the midst of that personal and professional identity crisis, I went back to work in the emergency department about 4 months after my accident, and I went back as a full-time wheelchair user. This is me with a lot of my team, the leadership team, some of my nurses and care partner colleagues. And I remember when I went back, I was thinking to myself, like, at least I'm going back to work in a hospital. And so things will be accessible for me. And I was incredibly wrong about that. Uh, and that impacted me not only in my job, trying to do my work day to day, but also as someone who suddenly was seeking out healthcare more often than I ever had before. All of these barriers that had been invisible to me in my non-disabled viewpoint, they were suddenly everywhere, and I couldn't unsee them. They were now impacting me constantly. And so I also want to say that while I might share some of my own challenging experiences through this, it's only fair and appropriate for me to call out the fact that I had a wonderful and amazing team that I was able to return to, from my colleagues to my leaders in the hospital. I think we all did our best in pretty uncharted territory and found ways that let me return to work and to doing what I loved. That being said, it was a long and difficult and painful process. And without a massive amount of help from my family and friends and community and that work team and support, I really don't know how I could have done it, or at least how I could have done it without even more trauma being a part of that experience. So now that you know a little bit more about me and kind of my journey into disability, I want to talk just about some of the foundations of disability. We're going to discuss what disability is, the impact of ableism, some language that you likely hear used, and also the impacts of disability in the health of our communities and also within the healthcare workforce. So before I get into some of the different definitions of disability, I'm going to give you all about 30 seconds or so to think about what disability means to you. What are some of the key defining characteristics? And go ahead, if you feel comfortable and want to, put some of those thoughts about those key concepts into the chat. And as you're thinking about that, I've seen some people in the chat sharing some of their own experiences and stories with disability, and I want to say thank you for doing that. I also recognize that my experience of disability is going to be very different from many other people's. I'm seeing some great things coming in here. Needing assistance, barriers. Some disabilities are visible and others are not. Abilities might just be different from the norm, needing lifestyle changes, changes to all of your relationships. Thank you so much. Keep putting those in the chat as I start going through some of the different definitions here. So I'm going to start with the CDC definition, and they say that a disability is any condition of the body or mind, or so an impairment, that makes it more difficult for the person with that condition to do certain activities. So there's activity limitation. It also makes it more difficult for them to interact with the world around them. So there's the participation restriction. Those are really the three key concepts that the CDC currently is considering for having a disability or a functional disability. Now, on the other hand, the World Health Organization takes this a little bit further. They say that disability is the result of interactions between health conditions and environmental factors and personal factors. So it still incorporates those three key things of impairment, activity limitation, and participation restriction, but it brings in how the environment and the personal unique factors of each individual impact those items. I also want to recognize that there are many different ways to classify or group different disabilities. And I've seen this come up in the chat a little bit so far, that there are both visible and invisible disabilities. And I think that this is important because oftentimes people face different types of barriers, whether they have a visible or an invisible disability. And again, I'm going to speak some from personal experience and from those that I have had good disability conversations with. Oftentimes, visible disabilities are, it is something that is seen, where an invisible disability is something that is not, not visible just looking at somebody. However, the Invisible Disabilities Association, they had some really interesting thoughts on this. And they said that it creates more context by saying that the impairment caused by the disability creates a visible difference or a support need. So it's the impairment caused by the disability is what you're actually seeing more often than the disability itself. I also think that this is important to recognize because many people with visible disabilities, such as myself as a wheelchair user, often have invisible disabilities as well. And I can tell you that on any given day, it's more often the invisible parts of my disability that I find to be limiting or to be more challenging or to create more barriers for me. The fact that I can't walk between places, which is signaled by my wheelchair use, that's usually a lot easier for me to manage than the invisible parts like chronic pain. So recognizing that people are not just having one or the other, sometimes people can have both. And also visible disabilities, because they're seen, again, speaking from experience, oftentimes people will insist on helping me. They insist that I can't do it because I have a visible disability, regardless of what I tell them I have or what I need. On the other hand, I have a few friends and colleagues with invisible disabilities who have the very opposite experience. When they ask for what they need in order to participate fully, they are not believed. And so recognizing that depending on the disability, people's experience with those different barriers that I'll talk about today might be very different, but they are still there, regardless of if it's a visible or an invisible disability. And so I want you to think back to some of the things that you put into the chat or that you were kind of reflecting on with your own definition of disability or those key concepts. And how are there any of these that really relate to you or to what you were reflecting on? And I'm seeing lots of great things coming into the chat around the disability experience and some of those key concepts. And I think it's important to know that, there is no one gold standard, this is the ultimate definition of disability. Depending on where you look, depending on the context disability is being viewed through, those definitions do shift. All right, so now there should be a poll question um, that will be available to you to think about how those different definitions related to some of the key concepts that you identified up front. Give everyone about 15 seconds or so to answer. And I'm still seeing great things coming through the chat. Really, some of those differences between the visible and the invisible disabilities and how society often views them. Okay, and so here I'm seeing that some people had thought of, some or all of those key points, but also a lot of people identified that maybe there were some other nuances or some aspects of disability that they hadn't thought of before. And I love that. This is all about kind of unlearning a lot of the preconceived ideas that we have around disability and broadening our own understanding. So thank you so much for participating in that. Thinking about ableism. So ableism is essentially disability discrimination. But we're going to talk about some of the specific definitions again or approaches to what ableism is. So if you just go to, the dictionary, it will tell you that discrimination or the ableism is discrimination or prejudice against individuals with disabilities. The American Psychology Association takes it one step farther and says that it often includes this patronizing desire to cure people of their disabilities and to make them more normal. And we'll come back to this in a little bit. But I particularly like this Eisenmenger definition in 2019. And she says that it is the discrimination and social prejudice against people with disabilities based on the belief that typical abilities are superior. It classifies entire groups of people as less than and includes harmful stereotypes, misconceptions, and generalizations of people with disabilities. And I feel that this is a much better depiction of the complexity of ableism, including both the implicit and the explicit bias, which encourages discrimination to happen against those with disabilities. So in a lot of the my own PhD research and work that I'm doing, I like this Eisenmenger definition from 2019. When we think about ableism, and actually this can apply to all isms, they can occur in different ways or on different levels. Structural is going to refer to organizational processes, societal culture, and things like that. It might be built in through unnecessary job requirements that limit the types of applicants that someone can or that you might receive for a job opening. That can also be for technical standards to get into nursing programs. Are there things written in there about the particular abilities that someone must have in order to be a nurse? Also, lack of accommodations. So is there a willingness on the organizational level or institutional level to help and support accommodations? Individualized is going to refer to more one-on-one or small group environments. This is often where we think of microaggressions occurring. It's at least one of the easiest places to pick out microaggressions happening. This can refer to people maybe using language that can be insensitive or harmful. And we're going to go over some of those terms in a little bit. It might also be changing the expectations for people with disabilities, whether that's making something easier for them or making something unnecessarily harder for them, but holding people to different levels of expectation and accountability. And then finally, we have internalized ableism. And this is something that is within each and every one of us. It's the ableism that we have within ourselves about the disability experience. And most people at some point in time, whether it's temporary or permanent, will be disabled. So I encourage all of you to start doing some of this work ahead of time so that at some point in the future, when you or someone that you know and love and care about is facing disability, that some of this internal work has already happened. And I can tell you that being a disabled individual does not mean that I don't have internalized ableism. It is still there and still something that I actively work against most days. So you may have heard, whether in the context of disability or just generally, uh, thoughts around identity first versus person first language. So in the context of disability, identity first language would be a disabled person, while person first language would be a person with a disability. And I am here to tell you that both of these can be okay. And it often depends on the identity preference of that disabled person themselves. You will hear me switch back and forth between identity first and person first language as I'm talking today. And that's really because I identify or have identified with both of these different ways of approaching disability. So when I was first disabled, I was very, very adamant that I was a person with a disability, right? Person first all the way. And that's fine. But I wanted my disability to be very secondary, right? It already felt like it had taken over so much of my life and how I was thinking about myself. I did not want it to become my identity. And so I was very adamant about person first language because I wanted you to see me, for the other things that I offered aside from my disability. Through a lot of work and understanding and unlearning about things, I've come to a place now where I really recognize that my disability impacts every aspect of my life. It can't be erased. And honestly, I wouldn't even want it to be. There is no part of my current self or identity that remains unaffected by my disability. And so now I'm at a place where I actually really prefer identity first language. My recommendation would be that if you are a non-disabled person, to, as a standard, use person first language, but never correct anyone in terms of how they want to be referred to. And if they refer to themselves in any certain way, that's how you should refer to them as well. So for instance, sometimes I get really cranky about Microsoft Word because whenever I am doing, writing up my research or putting together presentations, um, it will try to correct my grammar when I use identity first language. So if I say the disabled nurse or the disabled person, it puts a little squiggly line under there and tells me that I'm wrong. And that really gets to me because I am using it intentionally, right? It is a conscious choice to say disabled nurse, disabled person. Um, and so I don't like when I'm being corrected when I, as the disabled person, am making that choice. So just be aware of what people's preferences are. What are some other disability-like words that you can think of? And I want you to put some of these into the chat, and I'll go through some of them as I see them start to come up. I definitely have my list of least favorite and favorite words. All right, the first one I see up there is handicapped. Yes, this is one that you will see everywhere, right? It's on signs, it's on bathrooms, it's everywhere. And the term handicapped actually comes from a time when disabled people were not allowed to work in the United States. And because of that, the only way that they were able to survive was by begging on the corner with a cap in their hand. And so handicapped actually comes from that context of being so reliant on others for your basic survival. And so that's one reason that for me, I really dislike handicapped. I see wheelchair bound up there. That's another one. So common, especially in healthcare conversations, to say wheelchair bound. And this is so misleading. I am not bound to my wheelchair. I use it to get from point A to point B. I get out of my wheelchair many times a day. I work out. I have an adaptive mountain bike and an adaptive sit skiing setup. I drive. I sleep in my bed. I am not bound to my wheelchair. My wheelchair is what gives me the freedom to move more easily from point A to point B. And so it changes how you start to look at mobility aids. I see another one with differently abled or being dependent, right? All of these things that I'm seeing come in through here, some of the kind of the euphemisms, the words that people say to avoid having to say the word disabled, that can actually be quite damaging. Um, when you think about the word disabled, our society has given it such a negative connotation or context that people naturally then see someone with a disability, if it's a visible disability, and that same association gets placed on it. Because as a society, we've said disability is this bad, this horrible thing. And it's not. It just is. It's never going away. It will always be part of the human continuum and the human experience. And so recognizing that we want to remove that negative connotation around the word disability, and by replacing it with other words that we think might be more palatable, that actually makes it worse. Um, I also see in the chat here special needs. That one also drives me a little bit wild as well. So, as a disabled person, my needs aren't special. They are the exact same needs as any non-disabled person. It's just how we meet those needs that might be different. But I have the exact same human needs as every other person in here. Now, you might be wondering, what are some of the words or things that you can say that are okay? What is fine? And I would say, every person is going to be unique with the words that they choose to use to describe themselves and their experiences. Generally, the word disabled, that it is a descriptive word. We should use it. Also, the word accessible, right? When I think of, go back to handicap for a second, you see parking signs, handicapped parking. It's not handicapped parking. There is nothing about the parking spot that, you know, is handicapped. And I don't like that word to begin with. It's an accessible parking spot, right? It allows those dashed lines on the side of that parking space allow me to get my wheelchair in and out of my vehicle so that I can go places independently easily. So accessible is another word that I really like in terms of what words are good to say around disability. And again, this comes back to the idea that we should not be afraid to use words that are describing an experience. So we should not be afraid to say disabled or disability. For instance, if you say, whether it's out loud, if you have the privacy and the comfort of doing so, saying our presenter today is disabled, right? I'm not offended by that. That is a descriptor of who I am, and it makes me feel more seen that you understand this background and this viewpoint and perspective that I am bringing to the conversation. Now, on here on the screen, I have the disability pride flag, and this is important. And I just want to make a note here that there are many different types of disabilities. So this flag particularly demonstrates through the different colored stripes, physical disabilities, intellectual and developmental disabilities, invisible disabilities, mental health disabilities, and sensory disabilities. And then the black in the background behind those stripes, that refers to the disabled people who have died due to lack of access to meet their basic needs, including things like healthcare. Um, and I just want to make one quick comment. I saw in the chat there that some people can actually be offended when you call them disabled. And yes, that is very true. If someone refers to themselves in a certain way, always respect that as the most important thing for that interaction with that person. Just knowing that more globally, words like disabled or accessible they are good to use to try and dispel some of that negativity that is culturally built around them right now. Also, I have on the screen here a QR code. This will take you to the Harvard Implicit Association testing, and there is one specific for disabilities. We don't have time to do it all here together. It takes about 15 minutes or so, but I would strongly encourage you to scan that QR code and do that at some point later and understand where your current level of implicit bias towards disability is. It can be a really helpful thing for anyone in here who is in academia or post-licensure education as well. These implicit association tests are great for helping people do some reflection before you bring up a topic. I want to talk a little bit about the impact that disability has on a large scale here. So in 2024, close to 29% of adults across the United States, which equals about 70 million people, had some type of functional disability using that CDC definition. Now, worldwide, I was not able to find a comparable adult statistic, but again, in 2024, the World Health Organization estimated that about 16% of the world's total population had a disability, and that equals about 1.3 billion people. And these numbers continue to increase both in the US and worldwide. And it's important to recognize not only are the disabilities present, but there are some unique health disparities that people with disabilities face. I have some of them listed on the screen here: obesity, diabetes and heart disease, preventative screenings, depression, among many others, cancer rates. There are many different health disparities that people with disabilities face for a variety of different reasons. And I want you to think a little bit about why these might be present as I go through the next couple of slides. And if there's anything that sticks out to you, again, put it in the chat and share with us. So as we start thinking about health disparities for disabled people, I think it's really important to recognize that there are different models of disability within healthcare and within society. The medical model of disability is what most of us in healthcare have kind of grown up with. And it's a lot of what is unintentionally perpetuated through nursing schools or other formal academic centers, as well as in clinical settings, even in post-licensure continuing education. This is the idea that disability is one of the worst things that can happen, and that life after disability is less worthwhile, less valuable, and oftentimes less important. It looks at disability as a defect, something that needs to be fixed or eradicated. And in the case of this wheelchair user here, you see them in their wheelchair at the bottom of the stairs. And it looks at the medical model, looks at this situation and says, if we can fix your legs, right? If your legs can be strong enough again, you can walk up the stairs like everybody else. And it makes disability this individual's problem, right? For if it was me in that situation, it is my problem. There is something wrong with me as a person. However, on the far other side of this, we have the social model of disability. And that really looks at disability as part of that human continuum or the human experience. And it says that society needs to be a part of creating environments in which disability doesn't mean limitation. So they would look at that same person on the bottom, at the bottom of the stairs, and instead of saying, well, hey, if we can, if we can fix you, disabled person, then there's not a problem. The social model says, why do we have stairs? If we just build a ramp, then anyone can use it, regardless of how they need to get up to that space. So I want to come back to the fact that in healthcare, the medical model is really highly used and ingrained within all of the systems and the structures and policies in place within those areas. It creates spaces where disabled people are often seen as less than, which is really that foundation of ableism. And because of that, those environments inherently support inequities for care and outcomes of disabled people that are seeking care. And a bit of a spoiler alert here, those ableist thoughts don't stop at disabled people who are seeking healthcare. It's also extending into disabled colleagues, disabled healthcare providers. So recognizing that it is going across the continuum there. So I have another polling question for you here. Which model, when you think about the environment that you work in and just kind of picture it or think of maybe your last interactions just out in that space, what model of disability do you think that, or have you seen or have you felt most often in that environment? Would it be more the medical model or the social model? We'll give everyone about 15 seconds or so to make a choice there. So mostly medical, but I love that some people are looking at their spaces and also being able to recognize where there have been some societal or some structural changes that have happened to make those spaces more accessible. I really love that. And I think that these are things that once you start to see the different barriers, they're hard to not see anymore. They suddenly stick out to you everywhere, and you'll start to see them, whether it's at work or going to the grocery store, going out to dinner with friends or family. You'll start to see these barriers more often and recognize what are some opportunities to reduce those. So when we think about health disparities, it really all comes down to these three things: access, cost, and quality. So first, access from a very basic level could be physically getting into a building or having equipment that is accessible or accessible safely for people in different circumstances. So, that might be a mammogram machine that can be adjustable to someone who's using a wheelchair, or an adjustable exam table so that people can transfer safely onto that. For example with this, I don't remember the last time that I was weighed and I am in healthcare environments fairly frequently. And I don't live in a place where there is access to a wheelchair scale. And we all know from our nursing backgrounds that just trending a weight is one of the best ways that we can see if there's something concerning that we need to start addressing on a kind of a proactive or a preventative level. And recognizing that people with disabilities may not even get that, they may not have access to the very basic preventative screenings. It would be as if you walked into your doctor's office and they asked you what you thought your blood pressure was today, right? Like I can guess, I can tell you what it was 2 years ago, the last time that someone took it, but that doesn't mean that it's accurate or that it actually helps. And I see a comment in the chat that it's a violation of the ADA. Yes, there are many violations of the ADA when it comes to healthcare environments for people with disabilities. Um, and many of us, myself included, actively working against those, trying to make changes, but it is a slow process and there is only so much of my time and energy to go around. Um, but I agree, there are many concerns about ADA not being followed. Um, I also want to talk about cost. People with disabilities not only have lower rates of overall employment, but specifically full-time employment with things like health benefits. Add on top of that, disability is expensive. Some estimates have identified up to $1,000 a month more as just to live, meet your basic needs as a disabled person. So if you think of someone making less money, needing to spend more money just to have their basic needs met, it might suddenly not feel surprising that things such as preventative cancer screenings or having proactive mental health care, right? That those are harder to budget in. And then finally, we have quality. So even if someone has access and they have the financial means to receive the care, it's clearly documented that disabled people have worse outcomes than non-disabled people. So the quality is still a concern. One of the primary identified things here is called diagnostic overshadowing. And this is what happens if someone with a disability enters a healthcare system with some sort of new symptom or concern. It often gets attributed to their disability rather than having a full workup and identifying if there may be another cause. And that often means delayed accurate diagnosis, which goes right in line with disease progression and typically worse outcomes from that. Now, research gives us some guidance when it comes to improving health disparities for marginalized populations. And this is not, this is shown clearly in the literature when we're looking at things like race and gender. And specifically, I'm talking about a representative healthcare workforce and nursing healthcare workforce. And so from this point forward, I'm going to really be talking about the importance of disability representation within nursing as a way to help and combat or reduce some of these barriers that are present. So I think we're all very aware of the fact that there is a nursing shortage. It's going to continue not only in the US, but globally as well. And there are many different factors that impact this. And disability in and of itself actually impacts all of these things that are here on the screen: burnout, injury, people needing to retire early, not having enough faculty, etc. So when we think about recruitment, there's really two ways to impact this nursing shortage when we're thinking about disability. We need to recruit and we also need to retain. So recognizing that there are barriers for people with disabilities getting into the nursing profession. And that starts with just getting into nursing school. Do they even realize that it's a potential option for them? Did they have the support that they needed getting through high school and prerequisite courses, or actually getting into the school itself? Then we have disability disclosure. Oftentimes when people have the opportunity or the ability to not disclose their disability, frequently they choose to keep it hidden because of the stigma and discrimination that's present. So being very aware of the fact that if you're working in an academic institution, you need to have a pro-disability stance and things in place so that people feel comfortable disclosing and getting the accommodations they need to be successful. And that includes both classroom and clinical accommodations. When I go around and speak with, I do a lot of speaking at academic institutions, and classroom accommodations are quite common, but clinical accommodations are things that people still feel uncomfortable about. And so, how do we work together to allow for appropriate clinical accommodation so that people can effectively go through nursing school? And then job application support. So recognizing oftentimes it someone with a disability who is just graduated nursing school, they might need a mentor or a professional reference, someone to help them understand how to kind of bridge that distance between school and their first job or first place of employment. I think it's also important to recognize here when we're talking about recruitment and entering the nursing profession. Gone are the days that in nursing school we should be, you know, educating everyone or getting everyone ready to go be a night shift nurse on a med surg unit, right? There are so many opportunities within the nursing profession. We need to make sure that we are helping people achieve whatever it is that their goals are. When we think about retention, this is all about staying in the profession after, whether it's after an injury or a disability occurs, or maybe it worsens over time. And again, looking at how do we create an inclusive space so that people feel safe disclosing their disability and receiving appropriate accommodations. And this kind of comes back to some of the ADA conversation earlier, but how do we move forward and recognize that there are so many benefits that people with disabilities bring to healthcare that it is worth making those accommodations? And then just, again, the number of different job roles that are present. If someone can no longer do one aspect of nursing, there is likely something else that they can do. And so being creative, being flexible, and being supportive of people as they're working through that. So how do we move forward into an inclusive future? I have spent a lot of time in leadership roles and running residency programs, seeing people come in and identifying really what are some of the key qualities that helps nurses excel in their role, regardless of what that role is. And these are some of the things that I have identified previously as being kind of, I would say, aspects of a nurse that go beyond skills, right? This is all about how do you approach situations. And what I find is most interesting is that these are all qualities that people with disabilities are forced to excel at, because there is not a time or a day that I leave my house that I don't have to practice multiple, sometimes every single one of these skills. And they are skills that can be learned, that can be improved upon. And so people with disabilities bring so many of these aspects to their work. And so recognizing that this is just as valuable as being able to perform a technical skill or a physical task. And so I don't want to ever make it seem like the barriers aren't there and that they aren't real. What I want to encourage you to think about is that even with those barriers, the benefits outweigh them. There is still so much to be gained from including disabled people within nursing and within healthcare. And so, what are some ways that we can do this? When we think on a systemic or a structural level, really focusing on that social model of disability, how can we build things so that we proactively alleviate some of those barriers and also move more towards a strength-based culture rather than every nurse has to be able to perfectly do every single thing? Recognizing we all have strengths and weaknesses. I will be the first one to say now that I am not the person that you want, unless it's a neonate, like I am not the person you want giving CPR. But I am the person that you want running the defibrillator, because I can do that no problem. And which of those tasks usually has a bigger line of people waiting and excited to do it, right? So what are your strengths? How do we play into that? On the individualized, those small group or one-on-one level, Think about allyship. If you are a non-disabled individual, how can you encourage the voices of disabled people to be included? How do you, if you see a barrier, you see a concern, how can you move forward and try and help someone address that? As I mentioned earlier with talking about the scales and a lot of the ADA non-compliance, there is only one of me and I just can't mentally manage bringing up every single thing that I see that I know should legally be fixed. I would be a miserable, exhausted person, and my family would not appreciate that. So if you see that, you can speak up too, being an ally and having radical trust. One of my great colleagues um, out of the University of Illinois Chicago, she talks a lot about radical trust. And if a disabled person tells you this is what I need in order to do this work or to get my job done or to be more effective or productive, believe them. Even if you aren't sure why or how it makes a difference, believe them. Because disabled people already self-accommodate and avoid asking for as much as humanly possible. So if we are to the point where we say this would really make a difference, just trust me on that. And then from an internalized level, remember that we are all human, right? We don't all need to be superheroes. Uh, we need to recognize that humanity is central to nursing. And part of that is that reflection and just recognizing what's everyone's doing the best that they can with what they have to give in that moment and supporting each other through that because we're all going to need it at various points in time. So you might be thinking, what can you do? And no matter your role, I want to let you know that there are things that you can do to help with this. So I want to encourage you to engage in some critical self-reflection around your perceptions, thoughts, and biases around disability. Do that Harvard implicit association test. See where your current implicit bias currently is and identify if there's opportunities. Really think about the benefits over the barriers. The barriers are often the easiest thing to see and that come to mind. But instead, think, okay, if we make this accommodation, if I do this thing a little bit differently, does it help this person stay, either enter or stay in the profession, knowing that they will be able to bring all of those other great qualities? Be curious rather than judgmental if you see someone doing something differently. Oftentimes, people with disabilities, right, when I do things, I have to do it in a way that works for my body and my abilities. Just because it looks different doesn't mean that it's not safe and that it isn't a perfectly acceptable way to do it. And so it's fine to be curious, but don't judge someone if they're doing something in a different way than maybe what you learned. And then be accountable for your own actions and responses. I would never expect anyone here in this presentation to hear it, think about it, for the rest of the day and wake up tomorrow and be 100% non-ableist. I talk about this all the time. I research it, and I absolutely have ableist moments. What I try and do is catch myself when I'm having that moment, think about why I feel that way, and be intentional about making a different choice so that I don't cause unintended harm to somebody. And so that goes with being intentional about your behaviors. If you recognize that you've made a mistake, that's okay. We're human. We're going to make mistakes. But what can you do differently next time? And I have a list here of some of my favorite people to follow. These are their Instagram accounts, a variety of nurses with a variety of types of disabilities, including wheelchair users for multiple reasons, someone who speaks very openly about their mental health, invisible disabilities. I always put out there, Nurse Nicole she's a deaf nurse. She is in the UK. And so if you have interest in learning ASL, please don't follow her for those sorts of tips because British Sign Language is different from American Sign Language. So just a little plug there. She's great for learning about deaf nursing. would not be the right person unless you're in the UK to go to for sign language support. And then Crutches and Spice is the only one who is not a nurse, but she talks so much about disability and disability intersectionality with race and gender and other aspects. I learn from her every single time that she posts. So at the end of the day, we've been listening, or you've been listening to me about 45 minutes or so. Well, I want you to know, at least about me, is that disability changed my life in so many ways. But that's just it. It changed. It's different. It's not less valuable. I'm no less worthy of being called a nurse or an expert in my field. And I'm no less deserving of community support, which includes high quality healthcare access and professional access. My life just shifted because that is what happens when we are lucky enough to keep on going. And with that, I have lots of references here. And if anyone, I know there's only a couple minutes for questions. If we don't get to them or I don't get to yours, please feel free to reach out to me. I have my email address, my different ways online you can get a hold of me. And if you scan that QR code, it will just pop up an email directly for you to be able to get in touch.
Thank you so much, Vanessa. I think we could get through maybe a couple of questions and then we'll close out. And like Vanessa said, take this opportunity to scan that QR code with your phone in case we don't have the opportunity to get to the question that you asked. The first question we have is, do you consider nurses that are older being looked at as having a disability?
That's a great question. And I think that it would kind of come back to that that definition of disability from the CDC of it requires an impairment with activity limitation and participation restriction. So if someone has a condition, and it could be chronic pain, whether, maybe it's an old back injury, a knee injury, if that is something that is making it harder for them to go through and do their day-to-day tasks and live their life, then I think that, depending on that person, whether or not they would consider themselves disabled is different from whether or not they might meet that definition of having a disability, where likely they may benefit from some type of an accommodation to make their work easier.
Thank you. And do you believe the entry of disabled persons into nursing schools will act toward the right direction in changing attitudes toward colleagues?
Yes, I absolutely believe that. And that is something as I mentioned earlier, I've been doing a lot of work with different academic institutions, helping them review their technical standards, as well as providing support not only for the students, but for faculty and staff at those organizations or those institutions to make it more disability friendly so they can get people with disabilities in and successfully through the program. I think the more that we can openly talk about the fact that disability exists and it's not going anywhere, and getting rid of disability is eugenics, right? I don't want to go anywhere. I want to stay here and I want to keep talking to everyone, right? So the more that we can just talk about this, the better it is for everybody.
Right. I'm going to close this out since we're near the end, but please, if we did not answer your question, email Vanessa and she can answer your questions for you, or if you have any other questions. Thank you, Vanessa, so much for sharing your story today. Sigma is grateful that you took the time to share with this audience, and we look forward to hearing more from you in the future. We hope you enjoyed this webinar. If you have a story to share or are doing work in this subject matter, please consider submitting an abstract by October 3rd for CHUI 2026. Monica is going to go ahead and she'll put the abstract back, link back into, but I've seen so many different things in the chat. I hope that all of you will consider submitting an abstract. And then finally, we will post the evaluation link in the chat for you that you can go to receive your contact hours for this. All attendees will receive an email within a week of the webinar with the link to the recording and the link to the evaluation if you're unable to complete the evaluation now. Thank you so much for all of your time and take care.
Thank you.